Bone destruction due to bone metastases or multiple myeloma and bone loss due to hormone ablative therapies can lead to serious skeletal complications. Research has shown that rank ligand is an essential mediator of the underlying biological mechanism of cancer-related bone diseases across tumor types. Bone is a dynamic tissue which undergoes constant remodeling through the coordinated activity of specialized cells called osteoclasts and osteoblasts. Osteoclasts are specialized cells that resorb bone, while osteoblasts are cells that form new bone. Osteoblasts express rank ligand, which binds to rank, a receptor on osteoclasts and osteoclast precursors. This binding promotes differentiation, activation, and survival of osteoclasts. Mature osteoclasts attach to bone and secrete enzymes and acids to form a resorption pit. Osteoblasts migrate into the resorption pit and produce new bone matrix, which mineralizes. In healthy adult bone, the body regulates rank ligand activity to balance bone formation and bone resorption. In many cancers, the skeleton is the most common site of metastases. Studies suggest up to 75% of patients with advanced breast cancer can develop bone metastases. Similar numbers are seen in prostate cancer. In patients with bone metastases, rank ligand is an essential mediator of the vicious cycle of bone destruction and tumor growth. Tumor cells that have invaded bone secrete cytokines and growth factors that stimulate osteoblasts to overexpress rank ligand. As a result, increased rank ligand signaling drives excessive osteoclast activity and bone resorption. In turn, increased bone resorption releases growth factors from the bone matrix, which may further stimulate tumor growth, thus perpetuating the cycle. Bone disease will develop in 95 to 100% of patients with multiple myeloma. Multiple myeloma cells in bone marrow increase expression of rank ligand and other factors that increase bone resorption. Increased bone resorption releases cytokines and growth factors from the bone matrix that may further stimulate the growth of myeloma cells and contribute to a vicious cycle of bone destruction. In addition to increased rank ligand-mediated osteoclast activity, concomitant inhibition of bone-forming osteoblasts further exacerbates bone destruction. Breast cancer lesions often appear osteolytic. While prostate cancer lesions are often blastic or mixed, there is significant osteolytic activity that in some patients is comparable with or higher than that seen in breast cancer and multiple myeloma. This vicious cycle of rank ligand-mediated bone destruction and tumor growth can lead to devastating pathologic fractures and other skeletal-related events, including palliative radiation to bone, surgery to bone, and spinal cord compression. Patients with breast cancer or prostate cancer receiving hormone ablative therapy are at significantly increased risk of developing bone loss and subsequent fracture. In patients treated with hormone ablative therapy, reduction of sex hormone levels leads to an increase in rank ligand expression. This drives excessive osteoclast activity, causing systemic bone loss, which can lead to devastating fractures. Rank ligand is a key signal across a continuum of cancer-related bone diseases. In patients with bone metastases and multiple myeloma, rank ligand drives excessive osteoclast activity, contributing to a vicious cycle of bone destruction and tumor growth that can lead to devastating fractures and other skeletal-related events.